Hi everyone, welcome you all to my YouTube channel. Today I'm going to discuss another MCQ with the background theory also. These MCQs were taken from AMC handbook. As you all know, as IMGs, when you are preparing for AMC exam, you should be able to at least once complete this AMC handbook. So these videos you can use as a guide because I am explaining the background theory also to each stem. So at the end, just near to your exam, you can go through all these videos and you can use this to recall and review and refresh your knowledge prior to exam, and this can use as preparation for exam because you don't have to read all the books. Here I am explaining all the theories. Okay, the MCQ is a 5-year-old child presented with rash on his back and trunk over duration of 1 week, but generally the child is healthy. No, the child is not an ill child, and rest of the clinical examination is normal. This is the history given to you. So they are asking the diagnosis. They have already provided the image of this skin condition. As you all aware, these dermatological conditions will repeatedly ask you in your exam. This is the image they have provided. Now just think of your answer. This is a very characteristic skin condition. I will tell the answer at the end. First stem they have given is impetigo. Let's see whether this is impetigo or not. What is impetigo? Just close your eyes and try to memorize the image of the child or anyone with impetigo. Impetigo is when we consider about the pathophysiology of the illness, it is superficial infection of the epidermis. These layers of skin very important, and usually due to Staph aureus is the main organism, and less commonly group A streptococcus also can cause this. Occurs in broken skin. Usually non-bullous impetigo is the commonest bacterial infection in children. Occurs in broken skin. Broken skin means bleached skin, and this is usually they describe this as pruritic skin lesion. They will tell that this is a pruritic type of skin lesion. The important thing is common organism is Staph aureus, less common is group A strep. What are the predisposing factors to get this skin condition? First thing is injury to skin. Second thing is genetic or inflammatory conditions of the skin, and other thing is cutaneous infections. All these three types you can think that there is a breach of the skin, superficial skin. There are two types, primary impetigo and secondary impetigo. Primary impetigo is basically due to minor cuts and ulceration. Secondary impetigo, there is an underlying cause, such as there are dermatological causes, atopic dermatitis, there can be insect bites, there can be sunburns, other dermatological conditions like bullous pemphigoid, or there can be the patient can have chronic lymphedema, and the patient can have cutaneous infections such as herpes zoster, varicella zoster, dermatophyte, herpes simplex sort of infection patient can have. Impetigo, when we consider about the signs and symptoms, Usually they present with, the main area affect is face, especially in non-bullous type. Then they can have pustules. They rupture and leave a yellow brown plaques. It's like a honey color plaques will be there, and they also can present with regional lymphadenopathy also. Usually on the face, non-bullous type is mainly face. The important term is here yellow brown plaques or honey color plaques will be there. Then I am going to discuss the two types of impetigo. First one is non-bullous impetigo. Usually the lesion size is 1 to 3 centimeter size, and there will be erosions with golden crusting. This term is important. Golden crusting will be there, and it can also have central healing and satellite lesions. But kept in your mind, the golden crusting is not the unique feature of this condition, but it is easy for us to identify non-bullous impetigo from this golden crusting. This is, you can see clearly, that's a honey color. Golden crusting you can see in this picture. This is the non-bullous type mainly. This is the typical picture you will get in an MCQ to identify the non-bullous impetigo. See, you can appreciate the main area which is affected was the face. Then there, as I already mentioned, there are three types. There are non-bullous, bullous and erythema. That are the main three types of impetigo. Then I am going to consider about what is this bullous impetigo. Then by the name itself, the skin lesions are bullae and vesicles which containing fluid or pus with surrounding erythema will be, you can appreciate the surrounding erythema. And what are the cause for the bullous formation is the exfoliative toxin of Staph aureus produce blistering by cleaving the cell adhesion molecules. This is the pathophysiology of bullous impetigo. You can appreciate the pictures of bullous impetigo. This will be the classical pictures which were given to you in your exam. But now you can see the initial case presentation is not the impetigo. So impetigo is wrong answer. But this can come as a next MCQ in your exam. So it is important to study around this step. So how the diagnosis? Usually this is a clinical diagnosis. We are not going to perform any test. But if you need, you can do gram stain of the skin lesion, gram positive cocci in clusters. In staphylococcus infection, you can appreciate clusters, and gram positive cocci in chains in streptococcal infection. Then you can also do the bacterial cultures of this skin lesion. We took sample from lesion, and when we do the cultures, you can appreciate the relevant organism. Then when we will quickly move into the management. If the localized area affected, like non-bullous, not a very serious form, you need to have a warm bath. Before applying anything, you need to have a warm bath and crust off. You can use topical agents like hydrogen peroxide, topical antibiotic ointments like fusidic acid, mupirocin, those type of ointment you can use. But if the condition is widespread, we move on to oral antibiotics also. Usually more commonly used ones are flucloxacillin and erythromycin also can use. And in the children, we much more prefer to use cefalexin. In young children group, the oral antibiotic we like to use is cefalexin. Usually drug of choice will be oral antibiotic if it is widespread. Next thing is I'm going to discuss is bullous impetigo, how we're going to manage. Usually bullous impetigo is rare, it is not that much common, and there will be flaccid transparent bullae which easily rupture, usually on limbs and trunk. Non-bullous in the face, and this one limbs, trunks, buttocks. Face also can affect. Treatment is antibiotic. We will use flucloxacillin, or as I mentioned earlier, erythromycin, cefalexin. Those sort of antibiotics can be used. Then there is another condition what we call streptococcal scaled skin syndrome. This can consider as a different skin condition entity, but this also a type of bullous impetigo. Usually there is this condition, they present with fever, diffuse erythema, and peppery wrinkling of the epidermis you can appreciate. Then this progress to blistering. Initially the area which affect is groin and axillae, easily burst, and this will give in the appearance of a burn. This is not much important, but just I mention here because there will so I do not have to discuss this again. Usually this is common in less than 5 years. Treat with, usually this need IV antibiotic, flucloxacillin like IV antibiotic we are using. Here I am not going to mention further more about the treatment. You can read around. So this is the summary. Non-bullous impetigo, papule vesicles and pustules rapidly break down from gold and adherent crust, often located on face and extremities. Bullous impetigo, flaccid fluid-filled bullae, rupture leaves a thin brown crust, often localized to trunk. Okay, this is the two main types. This is just a summary, non-bullous impetigo and bullous impetigo. Then there are other type is ecthema. Ecthema is punched out ulcers like thing. Overlying crust will be there, raised violaceous borders will be there. And treatment, as I already mentioned, limited we going to for topical mupirocin or retropermucin or fusidic acid like local application, or if it is extensive we going to go for a systemic antibiotics. If we suspect this is MRSA positive, our whole treatment will be different. So thank you everyone for your time, and please share, subscribe my channel and share among your colleagues, friends who are waiting to do AMC exam. So I hope this will be much more useful for you, because rather than reading lot of books, you can gain all the knowledge just by watching this video, like spending around 15 minutes. I will come with second stem of this MCQ. Now you know that skin lesion is not impetigo, so just think what will be the answer. We will be back with next stem. So take care, do your studies well, and wish you all the best for everyone who are preparing for the exam. Thank you.